I am so happy to have with me today my dear friend and medical expert, Dr. Geneviève Rochon-Terry. And Geneviève is a family doctor who works in Regent Park here in Toronto. Most of her patients are women, low income, and many of them are newcomers to Canada. And Geneviève has worked and trained in settings seeing many patients with substance use disorders. And IPV, intimate partner violence or domestic violence, is something she sees commonly as a doctor and is also something she's been involved in education and advocacy for the last 15 years. So welcome, Geneviève, and thank you so much again for joining me. And so just to kick things off, Geneviève has reviewed the case notes on this, and she'll be providing her perspective. But just as a general opener, Geneviève, can you tell me a little bit about the context or situations that you might see in which domestic violence or IPV might pop up in your practice? How does it come to you?
hmm Yeah, so it's pretty rare that people will just present disclosing that they're going through intimate partner violence or gender-based violence or domestic violence. Frequently, it comes up in the context of people coming in for other reasons. So frequently, there could be injuries they've recently gone through, but it could also be chronic pain that they're going through, which is or symptoms that we can't really explain. There could also be psychological illnesses going on, depression, anxiety, substance use. So very frequently, it's the context or the background for one of these other conditions, and it may not be relevant. It may not be apparent at first unless we're asking the right questions.
Right, okay, and so at that point, when those kinds of potential risk factors arise, you are then asking probing questions to get more information on that. Is that how it
Yeah,
would
we're
generally go?
asking probing questions. A lot of times, the way that we're doing this is asking about someone's history of trauma. Um, we know that adverse childhood experiences or ACEs are very important in people's risk later on of various physical and mental illnesses, but also, of course, violence or trauma that they experience later in life. So it's definitely good practice to be asking about people's history of any kind of trauma, and that can also be something that leads us into a discussion about current or past intimate partner violence.
Right. Okay, and then just before jumping into the specific questions of this case, on a related note, would you say that that kind of is that something that medical students get training on when they're in med school about how to identify and ask those kinds of probing questions to provide more, I'd say, I suppose, holistic care for a patient who might arrive in the family practice?
It definitely, I'm not sure historically. I think historically probably less so.
Yeah.
In the two medical schools where I have experience, so the one that I went to and then the one where I'm currently a lecturer, the students definitely are being trained on gender-based violence and how to ask about trauma.
Okay, great. So I guess it's more of a relatively recent focus, but now more generally
Yeah, and there's
understood.
definitely increasing awareness of the impacts of trauma on
Okay.
on current health.
Wonderful. Okay, thank you. So turning to the specific case that we are
Mhm.
talking about here, you'll recall that the griever at issue had presented with some substance use disorders and it also disclosed dealing with domestic violence or IPV at home. So could you speak about whether there is a medically recognized link between substance abuse disorders and domestic violence?
Yes, there definitely is a medically recognized link between substance use disorders and domestic violence, and this is caused by a few different factors. So first of all, we know that going through abuse, whether it was in the past or current contemporary abuse, creates chronic trauma, chronically elevated stress hormones, and this leads to a state of hyperarousal. And substances can be a great coping mechanism for this.
Mhm.
Obviously, many negatives to substance use as a coping mechanism, but it can definitely help folks to create a temporary sense of calm or kind of a numbing for their feelings, and allow them to get through the day. Um, in addition, survivors of domestic violence do have higher rates of depression and anxiety and post-traumatic stress disorder. And each of those things are independently linked to a risk of substance use. And then, as I was mentioning before, with the adverse childhood events or experiences, so the ACEs, which can increase risk of intimate partner violence later on.
Right.
Um, those ACEs also put people at a risk of substance use disorders later on too. So there's a link kind of in multiple ways.
Right. And so it sounds like there's also multiple layers that could further exacerbate the situation of somebody dealing with domestic violence,
Mhm.
especially as an employee in the workplace where these substance abuse disorders might come up. So this particular individual, they had demonstrated like an inability to recognize that they had an issue, and in fact, further denied having a problem requiring, I shouldn't say problem, a medical issue requiring accommodation or support, and that kept popping up in the case, and was in fact a factor in the ultimate decision when the grievor's dismissal was upheld. Now, is this kind of a lack of recognition or denial that an individual might have about a substance abuse disorder? Would you say there's a link, or could I even say an exacerbation by the emotional or psychological trauma that somebody might be dealing with because of domestic violence? And if so, could you speak on that a bit more?
Mhm. Yes, I think there's a few ways this could be the case. So, like I was mentioning, substance use can be seen as a helpful coping strategy for someone who is being abused, and it may actually be allowing them to function in their life. So they may feel like it's quite beneficial with as a tool to get through. Um, maybe they have a recognition that, eventually they want to stop or cut down, but they feel like, now is not the time. This is really helpful to me right now, and I don't want to um, add other things that would decrease my ability to function. Um, folks experiencing intimate partner violence may have an altered self-perception, or an altered self-esteem, and that could also make them have reduced insight into their substance use disorder. We also sometimes see dissociation as a
Right.
coping mechanism for trauma.
Hmm.
So that, of course, would reduce people's recollection of their substance use or the feeling of being connected to that substance use. And I think also just the stigma around both substance use and around going through intimate partner violence could lead to denial, because the harms of substance use could be minimized, or again, the harms of intimate partner violence could be minimized because of just the fear of seeking help or disclosing to others and feeling like, oh, it's not a big deal. I, it would be more risky to disclose than to continue with this.
Right. And so on a related note, as a layperson, I could see the potential for an added layer of difficulty recognizing or admitting to needing help in this case, because there was an incident described in the case where she was repeatedly assaulted, specifically in the head, and at one point even suffered a concussion. And so I think, generally speaking, from in the news and people being aware of, for instance, like sports cases, that concussions alone can cause significant memory loss or even change people's personalities altogether. So in this particular case where there was at least one concussion, but also 20 years of abuse where she was taking hits to the head, um, setting aside the emotional or psychological response, what about the physical impact that that kind of treatment or abuse over 20 years might have on an ability to recognize and accept help that's being offered?
Yes, absolutely. So one concussion can create cognitive impairment, memory deficits, changes to the way people are problem solving or judging a situation, even difficulty with communication. They can have low mood, they can have fatigue, chronic pain. So all those symptoms just from one concussion could really limit the ability of a person to have insight into their substance use disorder, have motivation to make changes. And then it sounds like, yes, we think maybe one concussion, but if she's going through multiple head or neck injuries, even if they're more mild, each of those could really exacerbate all of the post-concussion symptoms. And what we tend to see is that with each subsequent head injury or kind of whiplash injury, people's symptoms get worse.
And I have a related question to this again. There, in the case notes, there was also criticism of her inability to, sorry, one second, Charlie, can you just hold off on the banging? Just 5 more minutes, okay? ちょっと待ってな. I'll have to cut that out.
I couldn't hear that at
In
all.
the, Charlie, do you want to come here? Okay, then you just watch the digger, okay? Um, the there was criticism of the grievor, and in fact, there was an allegation that she was being a non-candid witness, for not being able to recall instances of, let's say, like problematic behavior in the workplace, or she straight up couldn't remember, whether certain chains of events had happened at home or what had happened at work. And there was, in fact, a quote in the decision where she said, I just didn't recognize who I was. I wasn't the same person. Or she said, I don't have any recollection at all of that period. And so again, the lawyers for the employer and even the arbitrators seemed to accept that this was a sign that she couldn't be trusted or that she was a non-credible witness. Now, based on what you're saying, it seems to me like that could in fact be like a very natural response, or consequence of somebody who's been dealing with that kind of trauma for several years. Could you provide your perspective on what you think about the employer's allegation that she might be a non-credible witness because of those statements?
Yeah, unfortunately, that's something we see frequently in these kind of gender-based violence cases, and in cases where substance use is involved. And I think there's a couple ways in which what I know about her past could have influenced that. So number one, the repeated concussion could have really impacted her memory and her ability to kind of thread together those timelines, especially under a situation of being stressed and kind of under duress in court. And then also, she may have been dissociating during times where she was experiencing trauma. Um, yeah, so I think both the kind of psychological coping mechanisms of what she was going through, but also the physical symptoms of the concussions could have caused that outcome.
Thank you. So my last question is about the union's failure to have called medical evidence to support a case for human rights accommodations in this particular grievance. It ultimately turned on whether or not there was just cause because the union never alleged human rights and never brought forward medical evidence of needing an accommodation. So I'd like to just turn more generally to hear your practice as a family doctor dealing with IPV. Generally speaking, the roles between HR and a doctor in an accommodation case is that the employer would ask for a description of the needs or limitations of a patient. The doctor would provide that without specifying a diagnosis, and then the employer would come away from that and then come up with an accommodation plan. But in the case of intimate partner violence, it's not as straightforward as saying, for instance, advice for ergonomic adjustments. So, do you have any examples, just generally speaking, about how you might go about advising an employer of just the needs or restrictions that someone might need to get an accommodation, but that's grounded in responding to domestic violence?
Mhm. Yeah, I think it is a bit it's a bit of a tricky one to think of accommodations for because as you said, it's easy to say, oh, this person needs a more comfortable chair or whatever. I think what I was struck by in this case is how isolated this person is. And, it talks about her mother's death and how she doesn't have access to a vehicle, I believe, and she's quite rural. And I think that's um, a big part of why she's also susceptible to domestic violence and isn't able to seek help as well. Um, so I was thinking about, are there ways that that could be overcome? Obviously, the employer is probably not in a place to change huge things about that. But one thing I thought about is whether she could have access to any kind of confidential peer support, which can be an important therapeutic tool for both substance use and those going through intimate partner violence. Um, and maybe that would help with her feelings of isolation. I also wondered about if just working around alcohol is triggering for this person and whether they could maybe be put into a role that's not around alcohol. There may also be other workplace triggers that kind of heighten their sense of hyperarousal, like even things like slamming doors or loud noises, maybe could be creating a PTSD type response. And then that would lead to them feeling unsafe and just not comfortable, and maybe lead to more chance of using alcohol at work. Um, and then certainly they do need to attend intensive therapy with a trauma-informed therapist. I find sometimes counseling that's available through an EAP program is very focused on how, just returning to work and kind of coping with workplace stressors as opposed to actually healing from trauma. And so I think probably and there can be a sense that it's not confidential and that it may get back to the employer. So I think time and insurance coverage to be able to attend again trauma informed therapy with a therapist that's experienced in these areas would be really necessary.
Yeah, okay. And so I know we're almost at time, but on a final related point to bring this full circle, if you were to provide that kind of recommendation for needs restrictions to then create an accommodation plan, and somebody like this who displays a relatively common response, which is and resistance to accepting help or even recognizing that there is a need for help, would that patient then come back to you and you would be involved in helping that individual come to a decision about needing to recognize having an issue and accepting help, or is that ultimately up to the individual to come to that decision themselves and you would take a step back until that point? And sorry, Charlie, can you just wait a second? A few more minutes. You want to come here? No? Okay. You can have Peppa Pig in 30 seconds. Okay? Can you go to the couch? Okay, thank you. Okay.
So good.
All right.
Um, yeah, so correct me if I'm wrong about this interpretation, but when doctors see people with substance use disorder or who are going through intimate partner violence, they're there are many reasons why people wouldn't want to um, be engaging in help seeking around that. A lot of times doctors will use techniques like motivational interviewing. So there's various therapeutic techniques that can be used to help to just to help move people along the path towards
Mhm.
more insight into what's going on and towards wanting to seek help. But it is definitely a journey, and it's like
Yeah.
with smoking cessation, we realize that people aren't just going to decide they want to quit smoking because we told them one time. So it's definitely a process, and I would for sure see that as my role as their physician.
Genevieve, this was very helpful having your perspective as somebody who provides care to individuals dealing with domestic violence. It's really important to have this added perspective because doctors are very much involved in the accommodation process in the workplace, and also really helps HR departments who might not have this kind of expertise and insight get a better understanding about how they can support individuals in the workplace come up with an accommodation plan and hopefully and ultimately a longer term solution to help people in the workplace.